Next, I'd like us to have a conversation on renal care. It's an important conversation because in there are issues of non-communicable diseases such as diabetes and hypertension that can cause, complications on renal care, the issues of dialysis, the issues of transplant, and also the immunosuppressive medications that transplant patients sometimes require. So I think we can unpack all of that and have a conversation around it. So we can start by somebody with a lived experiences on renal care. All right, you're already up. Please, the floor is yours.
Thank you. Thank you, Mercy. Your Excellency, distinguished ladies and gentlemen, my name is Gikonyo. I am the president of the Renal Patient Society of Kenya. I'm also the vice chair of the Non-Communicable Diseases Alliance of Kenya. I am a kidney patient myself, living with a kidney transplant. I got my kidney transplant in 2015 at the Kenyatta National Hospital. And I'm proud to say that between then and now, the good people at Kenyatta National Hospital have taken good care of me and other renal patients. And that's why I have known nothing but good health in those 11 years. Your Excellency, I represent a group of people who are considered to be the greatest beneficiaries of the Social Health Authority. And I say this because the cover we have for both dialysis and transplant is, honestly speaking, quite generous. A patient on dialysis in Kenya is covered for 2 sessions every week, each session at 10,650. If you total that for 1 year, it's 1.1 million shillings per year. Now, a lot of people would not be able to pay 1.1 million shillings to pay for 2 sessions per year. And therefore, the 7 or 10,000 people currently living on dialysis literally owe their lives to the Social Health Authority, and we don't take that for granted. The patients who are lucky and able to get a transplant like myself, we have a share package which covers 1.1 million. That is for pre-transplant evaluation. Then there is the transplant surgery itself. There is the donor nephrectomy, that's removing the organ from the donor. And then there is the post-transplant management. If you total up all those figures, they come to about 1.1 million shillings. And therefore, we are very grateful to the government and to SHA for this package. And we would like to encourage SHA to continue supporting us. We would like to encourage SHA to speak to us regularly because sometimes there are challenges, particularly access challenges, that need to be ironed out so that whatever is not going on well can be sorted out. And I would like to pick a few issues. The dialysis package, like I've said, is 2 sessions. But if a patient gets admitted, if a dialysis patient gets admitted to hospital, they are only covered for 1 session. And this is a bit strange because if you are on dialysis, you are already a patient who is unwell, but if you now need to be admitted, it means your health has deteriorated, which could probably mean you need more dialysis than the 2. Remember, international best practice recommends 3 dialysis sessions. But we only give 2 because that is what we can afford for now, and we understand that very well as patients. But we only get 2, despite recommendation of 3 dialysis sessions, we get 2 because that is what we can get for now. And I'm talking about now a patient who is getting 1 session because they have been admitted. So they will even get more sick because if they are not able to pay for the extra one while they are in hospital, then they will not get well very soon. But what is even worse, Your Excellency, there's a condition called acute kidney injury. And this is a sudden onset of kidney failure, either from an infection, an injury, an accident, or something like that. If acute kidney injury is tackled quickly and intensive care given, which would involve, for example, 5 full days of dialysis, there is an 80% chance that the condition can be reversed, kidney function will be regained, and the patient can go home well. But now when we only allow one dialysis session for this patient, because they are any patient, what we are doing, I'm imagining the reason we are doing this is so that we save some money. But what we end up doing, and this is very sad, is that we are saving 50 or 60,000 at the risk now of sending this patient to full-time dialysis, for which we will need 1.1 million per year, and they will have a very bad outcome and a reduced quality of life. So these are some of the things we would like that SHA to reconsider, so that people get the care that they need at the time that they need it, because some of the access rules, unfortunately, are not fair to the patients. We have, like I've said, a post-transplant package. This is a package which supports now the medication and the clinics that we need after transplant. I would like to thank your government and SHA, because this is new. This came with SHA. We had a dialysis package and a transplant package before with NHIF, but when SHA came in, we made a plea and it was accepted. We now have pre-transplant evaluation and post-transplant care. That we attribute to your government and social health authority. Again, we have some challenges with access. Some of them are from the system, particularly the DHA system. We have a very, very cumbersome system where we have to give a lot of paperwork. KNH has now gone paperless. Hata ukilipa pesa upate receipt siku hizi. Hakuna karatasi KNH. And we are happy because things have improved, things move quick. But when it comes to SHA, I have to go with 6 documents, which I have to submit, and they have to be scanned. And even the physical part of doing that and taking them through all this takes a lot of time. Sometimes the system hangs. We would like the SHA system and the DHA system to be streamlined so that we can also go as smoothly as the rest of the things. And sometimes we are forced to go home without drugs because the system hanged. And to respond to CS Duale, who mentioned about, sometimes people switching off the system so that we can pay cash. A lot of time when the system goes down, you can't even pay cash. It goes down, nothing can happen. It's a very difficult and sad situation. And people at KNH, for example, wouldn't do that. And like I have said, I've been with them for over 10 years, so I know them. They cannot switch off a system to make you pay. So whenever it happens, it's a genuine problem.
Okay, thank you, Gikonyo.
Yeah. Let me just finish, because the president gave us a challenge to talk about beyond 2030. And I have not heard anyone talk about it. So I would like to make some asks on that. And what I would like to ask Your Excellency, and some of these things I would need to seek your personal intervention, is that we need a renal registry. We need that because we would like to make data-driven decisions around kidney disease. We do not have a registry as yet, so a lot of figures we throw around are imaginary. But before we get there, I would like to make a plea to Dr. Mercy Mwangangi and the gentleman from the DHA. I know if you go into your system, you can be able to tell us, for example, how many people accessed post-transplant medication in one period, how many people accessed dialysis. And if you can share that information with us, including with Dr. Lesiampe and her team, and his team, they would be able to make better plans. And I'll tell you why. Currently, that post-transplant package is only available at KNH and MTRH. But they cater, KNH can tell you how many people they have transplanted since they started. But they cater for people who are transplanted in other hospitals, including outside the country. So they cannot be able to predict properly today how many people will come for clinic next Tuesday if they do not have this data. And so they find themselves in problems which they are not able to solve because there is some darkness around how many patients need this service and how do we prepare for them. So we would like Your Excellency for that. We propose that this registry is domiciled at the Center for Excellence for Urology and Renal Disease Services, which we have been promised will be commissioned very soon. And I saw CS Duale inspecting that compound recently, so I know there is something in the works. And if this can be domiciled there, then we can be able to interact with that. And we will have to have, like I said, data-driven interventions and preparation. Now, I would like to bring to your attention, Your Excellency, that the Kenya Blood Tissue and Transplant Service has, for very many years, been trying to come up with a deceased organ donation program. And the reason we are doing this is because currently, if someone needs a kidney transplant, they can only get a donor from within the family. So previously, before the post-transplant cover that I've said came with SHA, a lot of people are preferring to stay on dialysis because when they're on dialysis, they don't pay anything other than the subscription. But if they do a transplant, they need to buy medication, and they feel they cannot be able to do that. Now we have some money coming our way. And the question is, why haven't we seen an uptick in people seeking transplant services? The reason is kidney disease is a family disease. So if I am still being requested to go back to my family to look for a donor, there's a high likelihood that most of them will not qualify because if it's a genetic disorder, then they are all affected. And that now keeps people on dialysis because the only exit from dialysis is transplant. So if you cannot get it, you're stuck in dialysis. We think that your quality of life will deteriorate if you are on dialysis for more than 5 years. So the cure for that then is a deceased organ program where we can be able to take organs from our dearly departed and then we can use this for transplant. We can also relax the rule that requires me to go to the family so that now my friend or my neighbor can donate to me. The Kenya Blood Tissue and Transplant Services has been working on a framework to operationalize the law that is in the 2017 Health Act. And this process has been stuck since 2023 because of lack of funds. I would like to make a special appeal to Your Excellency and the Honorable CS for Health. Please make sure that this effort is funded so that we can be able to finish the technical working group that was working on this is able to finish this work so that we can expand the donor pool in the country and more people will be able to exit dialysis and go for transplant.
Thank you.
Just two more.
Thank
Okay.
you. Let's allow others
let
to
me talk about an NCD. I would like to request that I know we're having a census in 2015. Again, looking for data. We don't know how many people are living with NCDs in the country today. I would like to make a request that during the census, the next coming census, that we put a question on NCDs so we can have some semblance of data of the people living with NCDs in the country. And finally, I would like to make a plea for meaningful involvement of people living with NCDs at the decision-making level so that we can contribute towards some of these decisions, using our lived experiences, and that is the end for me. Thank you very much.
Thank you. Thank you very much, Gikonyo. You have packed quite a lot of things, and I could see the President taking notes. We will address that later. Allow me to also